Right.
Said
First
no.
off, it's not sunset camo. All right. So, good afternoon, ladies and gentlemen, from all around the interwebs. Welcome to episode 15 and the final episode of Coffee Compliance and Chuckleheads for 2021. As you can see, before we even got started, I was getting razzed by Eric Rubenstein, as only Eric Rubenstein can do. And of course, Jordan was trying to jump in on top of that because Jordan doesn't realize that his beating is about to come momentarily. But with that said, ladies and gentlemen, welcome to Coffee Compliance and Chuckleheads. As I said, episode 15, the final episode of 2021. It is hard to believe that we are here. It is hard to believe that we are at the end of this this year, and man, what a year it has been. So, with that said, gentlemen, happy holidays, happy past Hanukkah, happy New Year coming up, Merry Christmas, and same to each and every single one of our friends tuning in, logging on, and just hanging out with us for the next hour.
By the way, today is Festivus as well.
The old Festivus for the rest of us.
It's Festivus.
What is Festivus? Help me understand that. I'm
It's
just a
the
good old
Eric-
boy from
Come
South
on.
Georgia, man. What is Festivus?
We'll have to have it as offline. If you don't watch Seinfeld, you don't know. But it's
Oh.
it's the airing of the grievances, feats of
Yeah.
strength, and the
Yeah.
like. Yeah. All right.
Okay.
It's not Trailer Park Boys, apparently.
No, it's not. And if anybody's wondering, so yes, I've gotten some new spectacles, some new glasses, and it is definitely me getting older and having to get something where I can actually see. But with that said, and yes, this is not desert camo. This is not.
No, sunset. Like if you were in Sedona, in the woods of Sedona, or the desert of Sedona where the rocks are, I wouldn't be able to see you because you'd be blending in with that. Sunset camo.
Sunset camo. Outstanding.
I love it, guys.
Well,
I feel like there's a ton going on. I mean, this is the year of where health policy and changes are going to go literally to midnight on the 31st. They're not letting up.
No. And Eric, do you see what Jordan did there? He
Did you see that?
transitioned. He transitioned
Yeah.
as quickly away from a potential abusive situation
I
to
thought there was going to be a mustache comment. I mean,
the creeper. Okay, so with that said, let's get after this thing, man, because there is so much to actually talk about. And look, we're not getting away from this COVID thing, right? Okay, we're on to Omicron at this point right now, and the good news from both sides. The good news is that this is not as deadly as what we have seen with the prior variants. It is highly contagious. It is more contagious. Hospitals are now starting to get overrun. If you've been watching the news lately, you'll notice that we are almost out of, or there is a severe shortage of COVID tests. Not good. Not good. And the administration was asked, why are we facing a shortage of COVID tests? And they said, we just weren't prepared. That was literally the response that was given.
we had the COVID test, and then to Eric's point, the trying to get the monoclonal antibodies now. So we have a shortage of tests, and it's difficult to get the monoclonal antibodies if that's the case.
That's right.
The interesting thing is that and you've got on top of that now, we were just talking about this before we went live, is you've got the Pfizer drug and you've got the Merck drug having just been approved, but not yet available. I understand that they're going to be available early next year, like very beginning of January. But the problem is they are requiring a doctor's prescription for it. So, I think the problem with that is, to an extent, is you go to a testing center, you turn up positive, you want to go get these medications, you now have to go and find a doctor that can see you to be able to say, yes, you have a positive test, here's a prescription, versus, I think they were talking early on about the prospect of this being pharmacist driven, like getting a flu vaccine or something. So, I think the issue now becomes you're now creating an environment for a billing event for what I would otherwise consider nonsense. Like, what are you setting up a billing? You're essentially now going to have to go to a doctor, make an appointment, and get an E&M, which is going to be billed at a 99213, because the doctor is going to give you an exam. The doctor is going to take a history. It's going to be a 99213, ultimately to say, yes, you've got a positive test for COVID. Here's a prescription for the medication.
But let me share something with you real quick, because you started talking about levels of service, and I want to share something with you. So Aetna last week sent a letter to what appears to be they're going to become a new client for us. And Aetna said, based on CMS rules, and I've been looking everywhere for this, so if anybody has it or can find it, please let me know. Aetna is saying, based on CMS's rules, that the highest level E&M service that a physician can bill for COVID is 99211, and they are demanding more than $1 million back from this practice.
What? 99211 doesn't even require a physician.
It's a nurse's visit.
It's a nurse's visit. It's a nurse's visit for bandage changing, blood pressure checks, like that kind of stuff.
Coumadin clinics, stuff like that. And
Yeah.
what they're saying is, they're saying that there is a CMS rule, okay? There is a CMS rule that specifically says a physician can bill no higher than the 99211. So obviously, you know me. I said, prove it to me. Send me something from CMS that is the guidance you proclaim to be following, and we'll have a discussion. Otherwise, ain't happening.
I've been involved in this since the beginning, and I don't remember. And I was on every after hours call. I mean, we were all on those CMS.
We were on those. Yeah,
yeah, that's crazy.
Here's the thing, folks. There's no ifs, ands, or buts, right? Q4 really has kicked into high gear for the audits. We have seen an unbelievable amount of audits just in Q4. And this is setting us up very nicely for the payers and their contracted bounty hunters to be so aggressive coming into Q1 2022. I've said it 150 times. I'll say it 150 more. 2022, without a doubt, is going to be the year of the audit.
Yep.
On steroids. There's no ifs, ands, or buts about it. I think the DOJ is stepping up their efforts on civil investigative demands. I think criminal investigative demands are also going to start to come out. My very good friend, Robert Lyles, buddy, I'm praying for you, man. I hope you continue to stay well, get well. I'll see you in 2022, God willing. But, Robert and I, we are working on a case right now where, the doctors were like, hey, what is this thing? And we're like, it's a criminal investigative demand. And,
civil CID is
no. This was a criminal demand. This was a criminal investigation
from the U.S. Attorney's Office.
It was.
It would have been it's either a grand jury subpoena or a HIPAA.
It did not specify either, and that's why I was kind of scratching my head. But this is a criminal investigation, and there's a criminal AUSA that has been assigned to it as well.
Yeah, so that would be either a HIPAA subpoena or a grand jury subpoena.
Yeah, we'll have to find out. Yeah. But here's the thing, folks. The pandemic has created all sorts of opportunities. And one of the big opportunities that I see are for physicians and administrators to potentially make bad decisions. And what I'm talking about is with respect to refusing to see a patient simply because they're not vaccinated. This is not an opinion. The American Medical Association released their ethics guidance on physicians who refuse to treat a unvaccinated person simply because of their political belief, meaning that physicians, or simply because they're saying, you're not vaccinated and I don't want to care for you. I just got a phone call again today from a very good friend whose wife, she has tested negative for the last 2 days. They were both exposed to COVID over the weekend. And the crazy thing is they were with 2 other people in their group. Both of those people were fully vaccinated, and both of those people tested positive for COVID. Now, my buddy and his wife both have upper respiratory infections, but for the last 2 days, they've been going and getting, swabbed, and their tests are coming back negative. But she called her physician's office and said, look, here's the deal. You've been treating me for 30 years. I get upper respiratory infections every single year. Can I just get whatever it is that you think I need and let me go on my way? And they're like, no, we're not treating you. You're unvaccinated. And then she said, okay, well, what about a telehealth visit? And they said, we're not treating you via telehealth either. I can't listen to your lungs. So basically,
so is this doctor essentially firing the patient?
And that's the physician doing it. But then remember all those cases, and I guess they still exist, but when pharmacists wouldn't prescribe birth control, it was based on their political view or religious belief, where they just wouldn't fill birth control.
Yeah. Well,
so I think you're crossing some very rough lines as in the physician and the medical community with this.
Yep. All right. So Eric, you just put this up, right? Okay. So take
a look at that.
Yeah, these are the scenarios that were released by the American Medical Association. This document looks very familiar to me. Is this the AMA guidance on COVID?
It is 100%. I know I've looked at this a million times as well, right?
Okay. So application of the CPT codes, if you're a new patient to the practice, it's 99202 through 99205. And if you're an established patient, 99212 through 99215.
Yeah.
There's actually zero mention anywhere
of
the 99211.
I just scanned this whole document. I couldn't find 99211 anywhere.
Yeah.
They all start at 99202 because they're all going to include a physician.
That's right. That's right. So
we're all going to have a doctor's piece of that. So I don't know where that's coming. I mean, obviously the simple appeal on Aetna is show us.
Yeah,
exactly. They didn't even footnote it or reference it in the overpayment letter?
Basically, in the overpayment letter, they said that we're following CMS guidance that says the highest level of E&M service for a COVID visit is 99211. I have yet to see that anywhere in any CMS document that I've ever read or reviewed. Remember, I sat on a governor's task force.
Yeah, and I've never seen an instance where a payer makes that sort of assertion and doesn't footnote it.
Yeah. No footnote, no reference, no nothing. But again, you just actually pulled an AMA guidance document. I think that's the one from September of 2021, which was last updated version.
That's correct.
So ridiculous. So listen, I see lots of people joining on to the podcast now. It's actually really exciting to see the kind of numbers that are starting to pop up from all the different streams that don't show. Folks, the chat is on. We are happy to take your questions, your comments, your concerns, and let's just keep rolling with this thing. So, a couple of things. So we started talking about this this Chucklehead chief of police. I think we'll spend a few minutes on COVID if that's okay. We found this Chucklehead who is the chief of police in a small town in North Carolina, who basically is on administrative leave now for 2 weeks, followed by 6 months of probation, if my memory is serving correct. And what this individual did was he basically committed fraud. He put the public health at risk by encouraging officers to go to this pop-up COVID clinic, if you will, where they're calling it a self-administration clinic, and they can go and purchase a COVID vaccine card that proves they got the vaccine without ever having to get it. And this chucklehead basically said, look, here's the deal. After I got off of a phone call with a friend, I called 2 other officers who were not in my department and passed on information about what was described as a self-vaccine or self-vaccination clinic. I don't even know what that is. Have you ever heard of a self-vaccination clinic?
Yeah, it's a place where you go pay $50 and someone hands you a card and they say, thank you for your patronage. Yeah, that's what that is.
So what he basically
If that were me, I'd be there with the needle. I'd be like this. I'd be like, ouch, ouch.
So he says, I got 1 phone call, hung up, and made 2 others. I didn't sit back and digest the information, ruminate on it, or otherwise give it much thought. I just passed it on. Come on, man. Really?
You know, I mean, this gets back. So I wrote a I wouldn't call it necessarily an article, but I wrote a commentary today that appeared in the newsletter that we put out over here at Advise, and I just said, like, you know, the time has come for a digital vaccination system to be put in place. I mean, it's just, you know, whether states believe and governors of some states, you know, want to call it a passport, want to call it, you know, the man looking at you. The fact of the matter is, and you know, this was part of obviously the conversation we had last week, you know, with the counselor. But the whole issue of, like, resources are being spent on something that really is something that shouldn't have to be even a discussion. You know, unless you're a doctor or a pharmacist and you're taking a bribe, which is a whole other story, versus, you know, where you're going to upload a vaccination record to a state website or a state, you know, like Department of Health system, which is a whole other set of fraud. But I mean, if we just got these digital vaccination cards with the QR code or a barcode, none of these conversations would be going on, or I should say, we'd be talking about it once every 3 weeks versus every stinking week. It's such a frustration at this point.
Well, let's take it 1 step further, right? Because the Pentagon and their researchers have actually developed an under the skin sensor. And this sensor not only detects COVID infection, but it also can tell somebody whether or not an individual has had the COVID vaccine or they have the antibodies. And, you know, it's really interesting because one of the very first things that the chief scientist at the Department of Defense says, it's Colonel Matt Hepburn, who's an infectious disease physician. Basically, one of the first things he said is, look, this is not a tracking device. You know, because I think that was always the biggest concern that a lot of people had.
I think that's right. You know, but there's been, I know there have been attempts over the years to do like RFI, you know, like you go get your pet microchipped, right? You know, the dog or the cat gets microchipped, and then, you know, you zap it and it says, oh, you know, Skippy belongs to Sean Weiss, and, you know, here you go. And I don't know if your dog's name is Skippy, but I mean, it sounds like it could be. But, you know, but there have been attempts to do that with people with repositories of medical records, where you get, you know, in, you know, these RFID testers where they put it in the webbing of your thumb, and it serves as, you know, it serves as your, like, Apple Pay. It serves, but it has the effect of working as your medical repository, you know, through like an RFID situation. But I just, in today's age, you know, we're getting into 2022, and the fact that there's some chucklehead with a high quality printer and some construction paper making up a card, and, you know, you don't even need to put a real lot number. You put, like, you know, we were at Madison Square Garden, you know, a couple nights ago. The line was unbelievable because everybody had a card versus, you know, people from New York City, you can do the, you know, the quick scan, but, you know, it's some 22-year-old kid who's checking your ID to a card, and he's just looking at a card and he's going, okay, okay. And, you know, there's no rhyme or reason to it. You know, it could be a fake card, it could be a real card. If they just had this situation set up where you can get a digital card with a QR or a barcode, and it linked up to the State Department of Health, and there's a network you'd be good to go. Obviously, if I'm in Florida and I have it and I go to New York, there's got to be some way for these places to talk to each other and,
Right.
you know, to be able to just like, let's get rid of these cards so that we're not in a position where we're seeing people getting prosecuted for something that we could stop. I mean, we
Yep.
could absolutely stop this.
Yep. So the question becomes, do you think the Billy Joel concert is going to turn into a super spreader?
Probably because he sang most of the hits, so you're all singing along with him. So,
Spittle.
right.
And then, you know, what you're talking about reminds me of an old Tom Cruise movie, The Minority Report. Do you remember that one?
Yeah.
Where, like, you know, you walk along and everything says, "Hi, Sean Weiss. We have a new hat available for you today." Or,
But how
you
is
know,
that any
Jordan
different?
Johnson, they've made
How's
a
that?
new razor for shaving.
How's that any different from Facebook, Instagram, Twitter, LinkedIn? I mean, how is it's directed advertising, right? The Googles. So, like, how is it any different?
Yep.
The Minority Report just did it from, you know, reading your mind, but
No,
you
I
know, I
think it was
mean,
the eye. It
or
was
the
the
eye,
eye.
something, right? It was
Yeah, because if you
something.
remember, like when he was going to get those huffers, is that what they're called, huffers? At the very beginning of the movie, and then
Mhm.
like the guy was missing his eyes, and they were selling eyes, and that's how they were able to. He was
Right.
able to.
I just don't know with our level of intelligence and software how we missed the boat to go back to literally a pen on paper.
It's a good question. I don't know, but so that's what the Pentagon is working on. You know, they are using these to be able to track the number of COVID cases. See, and what they're saying is the subdermal implant is reportedly a tissue-like gel that was engineered to continuously test the wearer's blood, and it reports back to the government. I mean, I'm not getting one of those things injected under my skin. That's just, you know, good luck. I wish you all the best of luck on that. All right, let's get off of COVID. Again, if anybody out there, I know Jennifer McNamara's on. She's a coder extraordinaire. If you have found anything, Jennifer, out there that talks about whether or not a physician or a non-physician practitioner is limited to a 99211 for COVID-related services by the Centers for Medicare or Medicaid Services, share it with us, and we'll find a gift for you. Although I give you, Jordan and Eric, the gifts that keep on giving year round.
Man, that may be like, that's almost a COVID reference.
Yes, it is. So I want to, if it's okay with you guys, I want to transition over to telehealth.
Yeah, that's
okay.
I mean, it's a lot of all eyes are on telehealth and supervision. So I think we'll talk about telehealth first and then supervision. I know that's another big one going into 2022. But yeah, knock it out of the park. Let's go.
Yeah. So okay. So again, let's differentiate between telefraud and telehealth. Eric, you care to take away the discussion on the telefraud, and then we'll jump into some of the telehealth stuff.
Yeah. I mean, the telefraud is the traditional telefraud is the number one red flag, and no prior doctor or prescriber or provider relationship with the patient. I mean, that's the number one indicia that when you look from a data analytics perspective, the first interaction that the patient has with the provider is that their NPI number is used as the referring provider for the item, service, or procedure. So the telefraud is really, you know, the cold calling to typically the most vulnerable of people, the senior citizen population, the Medicare population, through the use of call centers. Those numbers are gathered through a number of ways, through the deep web, through purchasing call lists and patient lists and things of that sort from websites and from organizations that collect that kind of data, and then using that information to socially engineer an individual into agreeing to accept an item, service, or procedure under the guise that it was being done through coordination with the patient's primary care physician or something. And that's really the telefraud piece of it. It's just, you know, there's no foundational backdrop to the legitimacy. And, you know, while we're on the topic, before we move over to the Health, OE and I are from HHS OIG just put out a study on genetic testing and found that the costs related to genetic testing since I think last year to this year, I forget the time period, have gone up fourfold. And a lot of that is going to be the result of the result of things like the Telefraud. So genetic tests are running, the PGX tests and the CGX tests. Those things are running anywhere in the area of $900 to $1,200 a test. And when you've got that going up fourfold, and the sad part about that is it is a one and done test. So if you get this test done and they don't actually test for the right things in that PGX or CGX, and somewhere down the road your provider actually wants you to have this test, well, guess what? It's going to get denied. You can't get the test. And when I worked on my couple of cases in this regard, I asked CMS, like, what do you do? Says, well, the patient would have to file an appeal. There'd be a whole process to get it done. Try to explain that to an 85-year-old Medicare beneficiary who needs to go on Coumadin or a blood thinner, and had a PGX test in which that wasn't part of the metric, and now it suddenly is something that they need. Good luck with that, right?
Yeah, good luck with that. And real quick, Robert, I'm so glad that you were on. It's the AID, the authorized investigative demand, is what we were talking about. So thanks for clearing that up. And Jennifer shared let me see if I can share this real quick. I think this is it right here. Okay. Thank you, Jennifer. And to her point, I agree with her because I was reading through. So this is the document right here, and we can make this available for everybody a little bit later. The FAQs, I agree with you, Jennifer. I think Aetna is completely misinterpreting the FAQs on here, and I am pretty certain that what you were referring to was if they are being seen just for the purposes of the collection of the specimen, that could be billed as a 99211. But other than that, any service that is rendered by a physician and or qualified healthcare provider, i.e. NPPA, is billed under the regular evaluation and management services 99202 through 99205 and 99212 through 99215. So thank you so much for that. And then one of the other things, real quick before we move on from the AIDs, yeah, they're getting CIDs, OIG subpoenas, and grand jury subpoenas. So, welcome to the holiday gift giving season from the government.
And I just took a read of the DOJ's manual with respect to AIDs. And AID, I think, is just the broader name given to ultimately what is a CID, because there are no criminal. When I did the reading, it's really a CID. The big subpoenas out there are CIDs, which, if you remember years ago, Sean, the CIDs could only be issued out of main justice. And then there became delegated authority. And it used to take like an act, I would say an act of God, but it took an act of DOJ to get somebody at their at main justice to approve a CID. And then once that became delegated down to the individual U.S. attorney's offices, then you start to see CIDs become more prevalent. But the ones that you see typically more often are the HIPAA subpoena, because that doesn't have the grand jury requirements to it. And so there's on parallel proceedings, you can get served with a HIPAA subpoena, and HIPAA subpoenas are for things, right? It's HIPAA subpoenas not for people. CIDs can be for people or things, and the people would be for ultimately for deposition or depositional testimony. And then obviously in the criminal side, you have grand jury subpoenas for people or things. And that would be for an appearance at the grand jury if it's for people. And then the one that people I think get really a little perplexed about is the OIG subpoena, which is an administrative subpoena. It is really not vastly different than a HIPAA subpoena or a CID put together, because an OIG subpoena can call for testimony or it can call for things. And OIG subpoenas are approved by Office of Counsel to the Inspector General, but they're signed off by the highest ranking official at the organization at the regional level. So if it's if it's a criminal or if it's a investigation by a special agent, like what I used to do, it would be signed off by the special agent in charge. If OAS, Office of Audit Services, or Office of Evaluation Inspection is doing it, then it's the regional inspector general for audit or investigations. But I do a lot of training on this, and I actually in a lot of the blocks of instruction that I do, I talk about how knowing what the subpoena is and knowing who the signatory is can go a really long way in understanding whether you're a target witness or subject on a case. But yeah, I mean, they're coming, they're fast and furious. I just talked to somebody, today who talked about a subpoena that was issued that asked for 9 years worth of information.
Unbelievable.
It's a home health organization. So they're asking for, and this is before electronic visit verification. So they're asking for the hard copy timesheets for all employees for a 9-year period of time on a subpoena. I mean, you got to be kidding. You got to be kidding me.
That's unrealistic, and I'm pretty
Burdensome.
sure that's going to be challenged by defense counsel.
Yes, we're working with the defense attorney to say, like, that's just ridiculous. You know, and it's a large home health organization. I mean, they've got probably 200 or 300 employees. So you're talking about thousands of pages, and honestly, they're going back 9 years. You're not even required to maintain those records that far back.
That's ridiculous. Well, let's go back to the telehealth for just a minute. So on December 15th of 2021, the Centers for Medicare and Medicaid Services updated their telehealth.hhs.gov website. And one of the big things that they put out there is that there's more than 100 CPT codes that have been added by Medicare for telehealth services. There is a zip file that you can actually download. We can make that available. I'll update the podcast description, and I'll include some of the links in there for you. Keep in mind that, they also talk about the fact that coverage after COVID-19 is going to continue, but there's going to be some limitations on those coverages, right? Here's what I would say. Telehealth is going to be a huge, if not one of the biggest audit targets in 2022. I just think there was so much varying information that came out in 2020 and 2021 as to whether it was audio only, whether it had to be interactive, whatever it was. And you found variances from payer to payer. And I think what you're going to find is a lot of physicians, a lot of organizations made a determination to just say, we're going to do it this way. There's so much variance in the guidance. Let's just try to follow with what CMS has put out there. But again, remember, CMS has also changed their stance several times since the pandemic began.
That's right.
Excuse me.
There's been there were temporary modifiers, right?
That's
it was 95. Now it's, or it was GT. Now it's 95, or vice versa.
Yep. Right.
Right.
And then the place of services changed, right, to where
Yep.
it could be the originating site. Now it's back to place 2 or whatever it is. So, I mean, folks, we're not trying to give you every specific CPT code, modifier, diagnosis code. What we're trying to make you aware of, what this show is about, is bringing to light the areas where we are personally seeing from clients that are coming to us that we're having to engage with, to the attorneys that we're working with and assisting in these cases, as to what we believe are going to be the biggest audit targets, the highest risk areas for providers moving into 2022. It's going to be evaluation and management services. There is no ifs, ands, or buts about it. E&M services are the lowest hanging fruit. They're highly subjective. Physicians, a lot of the doctors that I've talked to in 2021, they're like, Sean, what are you worried about? They've administratively made this much more simple for me. I only have to base my E&M service on time or on medical decision-making. And that couldn't be further from the truth, because you're still required to have a clinically relevant history and exam. And it's not just time, it's time in conjunction to medical necessity. It's not just medical decision-making.
CMS always puts out an analysis. I think the last analysis that they did, the E&M error rate hovers over 40%. right? In the
So,
certs and the perm
yep.
audits, the
Yep.
error rate is in excess of 40%. So, you go where the path of least resistance is. I mean, if you're going to do an audit, why not audit E&Ms and then work your way down from there? It doesn't make sense to not do it. I mean, we do
I
work
agree.
on the payer side, and we're auditing E&Ms
Yep.
because they're, and we're looking at those level 4s and level 5s. I mean,
Yep.
because the CPT says, and the guidance from CMS is, these should rarely be used. If you're a provider and in an 8-hour day you've billed 10 or 11 99214s and 5s, and that's all you've billed, and you're not some subspecialty dealing with a very sick population of people, you're putting yourself on the radar. Whether those are properly documented, that's not the point I'm making. The point I'm making is,
Right.
if you're spending your day, and from a data, Jordan will say this, and you look at data, if 90% of the stuff you're submitting are level 4s and level 5s, you're just asking to be audited. I mean, that's, we say it all the time, like revenue preservation, revenue generation, and what are your billings? I tell people all the time, the OIG is looking at what you're billing. Why aren't you?
Oh, and then
Hey,
my fear of this is not only if they see what these outliers are, if they can't stop it on an audit, if people aren't careful, then the AMA gets involved and reevaluates these codes on the practice expense malpractice for the RVUs.
that's
And
such a great point, Jordan.
and we could end up in a bad bind if they say, okay, we're collectively we can't fix it, but collectively we can adjust the RVUs.
While you're talking
Well, that's
about
a good point.
adjustments, while you're talking about adjustments for a minute, I know my ADD is kicking in, so we're kind of all over the place, but we're getting a chance to touch so many different things today. Jordan, so one of the things that I'm curious about is how the conversion factor has been calculated for 2022, right?
Yeah.
So is it coming out at the end of the day that it is a 0.75% decrease, or am I mean, because I was watching the math and trying to figure out the multiple steps that were taken, because it was like 3.75%, adding back in 3%, then taking this and adding to this, then subtracting this, and then you come out with 0.75.
It's essentially exactly. It's essentially 0.75. That's exactly right. It's not the 3.75, which was contrary to what people thought is, oh my gosh, we're getting a 3% raise this year. No, you just didn't get the 3.75% decrease. You got a 0.75, which means that 3 is going to come back and bite you at a minimum in November when the proposed rule comes out. Interestingly enough, though, so what they said when they did this is they said, all right, we're going to mess with the conversion factor, 0.75. But it's not going to affect your reimbursement at all, because we're going to take care of that in the RVUs. Now, the problem with this is, then why adjust the conversion factor if it doesn't? So I went back to those RVU files. Several people posted them. I went back to those RVU files and looked. They didn't do it in the addendum B. They did it in an actual RVU file. And I've run those numbers. And for many, many codes, the RVUs, I mean, over 50% of the codes, the RVUs didn't change at all, which means the reimbursement would be affected by 0.75%, because I put them side by side. The practice expense, the malpractice, and the work expense stayed the same pre the S610 legislation. And then now with this updated, they're exactly the same. So, I think they need to, get rid of the Common Core math and do some checks on that really quick.
Get out your advocate. Get out your abacus and figure it out. Yeah, I mean, look, I just want to go back to the point that Jordan was making on the AMA. That's actually like a really important point, I think, that we just sort of glossed over, which is, if you don't want to change your behavior, then we'll financially change your behavior. So what you got paid for a level 4, if it really should have been a level 3, then we'll pay you for the level 4 for the level 3, and we'll pay you for the level 5 for the level 4. And then guess what? There may not be any financial difference between a level 4 and a level 5 at that point. But, unfortunately, I think at times, if a provider doesn't want to change their behavior on their own, then you have to create an environment in which behavior is going to is going to be changed. I mean, you see that with a lot of the, the perm and the cert, they're trying to get behavior modification, on that. Or the really big one where you see that is the TPE, the probe.
Yeah, targeted probe.
And educate. Yeah, TPE, targeted probe.
Isn't that a fun Friday? Doesn't that sound like a fun Friday night?
It does. So
first they target you, then they probe you, and then they educate you about what just happened.
I mean, but imagine that. Like, so that's essentially the financial equivalent of that, right? Because under TPE, I think you get 3 shots at the apple, right? So they do the first TPE, they do an audit, they give you your results back, then they do a second round a little bit later after they educate you, then they give you. But the problem is after 3 bites at the apple, you're still trashy with your documentation. Right. Then you suffer the consequence of prepay.
Well, let me tell you, it's actually more extreme than that. I was just looking at, these glasses are really distracting me. I just got a text from somebody and they're like, dude, you look like Elton John. I'm like, what? These glasses, they're going back, man. They're going back. I mean, I love the Rocket Man, but come on, man.
Elton John.
You don't call a good old boy from South Georgia Elton John.
Yeah.
That's
I think, but to your point, to your point before this goes sideways quickly, is we see this with technology. So our big issue in oncology right now is technology allows you to do things much more efficiently and replace the work that the physician does. And I tell people, just because you can doesn't mean you should. If you start adopting all this technology that automates everything, the RUC is going to go back and evaluate those codes again and be like, okay, the practice work expense used to be this, and now you're saying that it's not. I mean, we're setting the stage for some reevaluations of codes, and the data, to y'all's point, is what's going to show it. Our utilization, the abuse, the fraud, it's all going to show it.
Well, here's the thing. These TPEs, we've already seen a significant number come out just over the last 10 days. I think TPE is going to be on fire in Q1. I think it's going to be a very big project because remember, they probably had 1,000 cases going on that they shut them all under the PHE, right? And beyond that, I think what's going to happen is they're just going to open all these brand new cases, and it's just going to be a floodgate of all these things. But one of the things that I wanted to talk about, because you brought up prepayment reviews, right? So you have phase 1, phase 2, phase 3 of the TPE program. After phase 3, there's a couple of things that happen, right? One, it could either be a referral to the Office of Inspector General for further investigation. 2, it gets referred back to the MAC for prepayment review. But the third one, and this is where my good friend Robert Lyles, I know you're listening. The third one that we've actually seen coming out of the TPEs after the 3rd level is revocation. Revocation of a provider's billing number. Folks, it is happening. It is happening quite frequently. And the problem is once you go through a revocation of your billing number, good luck getting reinstated. Yeah. It is not an easy process, and it is an extremely costly one. And I know my very good friend, Robert Lyles, and I work with a ton of law firms, and I'm specifically calling out Lyles Parker on this one. The work that Ashley Morgan and Jennifer Papa and Robert Lyles have done on these revocation cases, I think they are winning 100% or close to 100% of their revocation cases with Medicare. So if anybody, and I put this out there because if anybody receives a notice of revocation from the Centers for Medicare and Medicaid Services, don't sit on it. Don't try to file your own appeal. You don't need to call me or Eric or Jordan. Give Robert Lyles a call because this guy and his team understand revocations like nobody else that I've had the opportunity to work with. So just wanted to put that out there.
It's a little similar, Sean, to when a provider gets excluded and you get excluded after 5 years. And after 5 years, you're eligible for reinstatement. There is no guarantee. And I think the problem is that providers, number one, they don't realize, hey, at the end, I need to reapply to get back in the program.
That's right.
Number one. Number two, it is not a guarantee. All the language of the regulation says is that at the conclusion of your exclusionary period, you are eligible to reapply. There's no guarantee that you're getting in.
I have a doctor who's in Arkansas, become a very good friend of mine over the last several years that I've been working to help him. Common client of mine and Amanda Waish and mine and Robert Lyles. We've had to have multiple attorneys work with this guy. His exclusion was for 10 years. And at 10 years, we reapplied and they didn't want to let him back into the program. And this guy pled guilty to one count of submitting a false claim, one count. And he never should have pled guilty to this. He had an attorney that he was working with. I think the guy was like 187 years old, never worked in healthcare before. But, this is the mistake that happens sometimes with our physicians. They just don't know. They think, oh, it's an attorney. They know the law. They can handle this. They can argue this. And that's not the case.
He did my closing. He wrote my will.
He did. Yeah, he did my family trust.
Yeah. It's true.
We laugh about it, but it's true.
But it is perplexing that if you're going to exclude someone for 10 years and then they apply and they don't get back in, why wouldn't they just make an exclusion of, if you really didn't want the person back in, then hit them for 15, because the mandatory minimum is 5 years, and then there's the aggregating factors. So if you've come up with the calculation where someone at Office of Counsel to the OSIG, Office of Counsel, Inspector General, has identified that the appropriate amount of time is 20 years, then give them 20 years, and at the end of the 20 years, let them reapply and let them get back in. There's a lawyer that used to work for OSIG that I'm very good friends with who does a lot of work in that area. And when he first left OSIG, one of the first things that he did was he filed a whole bunch of FOIA requests and got lists of all of these people who had been similarly convicted of things, but had very disparate exclusions. And looked and then reached out. He was pretty good about it. He actually reached out to every one of these people and said, "Hey, I think I might be able to help your case." To just kind of drum up business. But the point is that if you're going to get somebody, if you're going to be termed excluded for a period of like 10 years, then why not just let the person back in after 10 years? Otherwise, just make it 15 and be done.
Or why not just make it a permanent ban and say you're permanently excluded?
Or whatever it is. But think about it sort of gets at the end of the day to a resource management thing, right? If you're going to exclude someone for 10 years and then you're going to put them back in, or you're not going to let them back in after 10 years, you've just spent all of these resources working on that for really no reason.
Yep. As much as it's disturbing me to put these glasses back on, I'm going to, because I can't see. There's my Coke bottles. Yeah, Robert, under the new rules, just a couple of years back, CMS is now seeking to revoke providers for 10 years. I mean, most people after 10 years are never going to get never going to get re-credentialed anyways.
Right. And people need to understand that revocation is not the same as exclusion.
That is correct.
Exclusion is an OIG function. Revocation is a CMS directed function to the max.
That's right. And it's a revocation of your billing privileges.
Right.
Yes. All right. So talking about, because I'm having fun talking about all this audit stuff, right? This past week, while my wife was out of the house, because I'm actually officially on vacation. Yeah, I know it doesn't happen.
Nah.
But here's the deal. So I posted something about these cases, Eric, that you and I are working, where Medicaid is actually coming out and saying, we're not bound to any statistical requirements because we're Medicaid. We can do whatever it is that we want. And my argument was, not so fast, Medicaid, because there is a document out there and it comes from your old stomping grounds, Eric. Yeah, and this is actually from the Mafuku.
Yeah,
right?
Four Mafukus.
For Mafukus. That is correct. From the Office of Inspector General for Mafukus.
Yeah, and the thing that's interesting about this is that this was a document that the OIG put out. on statistical sampling for mafukus. But what's interesting is some of the things that we're seeing, which are coming out of a particular state, are actually not coming from the mafuku. They're
Right.
coming from the single state, from the watchdog organization.
Well, they're coming from these contractors.
Well, the one that we looked at was from the state's version of the OMIG. Some states have an Office of Medicaid Inspector General. Some of them have Medicaid fraud divisions. So they're just sort of the watchdog group on Medicaid billing and coding, and they make referrals to the mafuku. So, one argument I could see one of these organizations making is we're not bound by this because we're not the mafuku.
Yeah, I
don't know if I agree with it, but I'm saying I could see that as an argument. This is a toolkit for Medicaid fraud control units. That's the law enforcement, the OIG counterpart.
I get it, but my counter argument to that is this is for a Medicaid investigational organization. So if a Medicaid investigator has to follow right here, step by step, statistical sampling methodologies, then I find it egregious that a state contractor is going to come out and say, we don't have to abide by this. We can do whatever we want. And correct me if I'm wrong. They had no semblance of statistical sampling. They basically said there were 118 claims. And of those 118 claims, there were 19 claims that had errors. But the problem was the errors were in different categories. So you couldn't look at one specific category. Like, for example, you were saying before 99214s. And you couldn't say, well, there were 19 errors out of 118 claims that were all tied to 99214. Thus, my error rate is X or my point estimate is Y. You can't do that because some of it was, they signed the note 7 days after the encounter was over. Another one was they had the wrong diagnosis code. But what they decided to do was they just picked the denominator or the numerator. I'm terrible at math, but they picked the number 19. And they said, we're going to use the number 19 and we're going to call it an
overall percentage
as the overall percentage rate.
So what you really got to do is you got to look at each category of error. So let's say they find that there's an error in 99214. Right. What number of so if it's 200 claims and 10 of those claims that were reviewed were 99214, then it's a 10% error rate to 99214 if it's statistically significant. And then you look at each one of those individually, and then you add up what those losses are. I mean, the one that we looked at was a home health organization, and they had one claim that was out of all of them. There was one claim that was an error in the category involving the employment certification. But they added that in with the other 18. They could have had thousands of employees and said this represent really one out of, say, 200 claims, which would have represented less than 1% of the error rate to do this. I think for me, the argument is that if an OMIG or a Medicaid fraud division is going to do statistical sampling, the reason why they should follow the mafuku toolkit is because there is a chance that audit is going to result in a referral to the mafuku, which is going to result in a criminal investigation by which a mafuku prosecutor is going to make a prosecutorial decision based upon that chain of events. A mafuku is not going to reinvent the wheel. They're going to rely upon that, in the way that they're going to do it. When we would get referrals at the OIG from the UPIC, we didn't reinvent the statistical sampling wheel. We relied upon what the UPIC did to come up with our theory of the fraud.
Yeah. Well, here's the thing, and this was again in New Jersey. And, I don't know if you remember, but, over the last couple of years, we had several cases with one of the, with the Medicaid payer in New Jersey. And we argued that their extrapolation couldn't be used because there was no statistically valid random sample that resulted in an upper or lower bound of a 90% confidence interval. They didn't realize what they were doing, and they, as a result, had to throw out all the extrapolation. And they're like, well, we're going to just go ahead and redo the statistical sample. And they redid it again, and they messed it up again. They didn't even get it right the second time. It's just, I guess my whole point of bringing this up is, you gotta assemble the right team. You gotta have the right people who understand this stuff, who can look at it and call BS, and who can say, absolutely not. This is a contradiction to everything that we know from a general principle of accounting standpoint. This goes against the MFPS, right, which is the investigational arm of Medicaid, who's bound by using this, who, to your point, if there's a high enough error rate or there's suspicion of fraudulent or abusive or wasteful activity at a Medicaid carrier, they're going to make the referral off to MFPS.
Right. Well, I think the problem is that what we've seen is that there is no threshold, right? Like, we see on the CMS side, typically if your error rate is greater than 50%, they could trigger a statistical sample. But, even providers who are under corporate integrity agreements,
right,
if they do a sample and their sample from their IRO is, I believe it's 5%, right? If it's below 5%, they don't even, it's ignored. Like,
yeah,
okay.
They actually just changed that rule, as a matter of fact, for the IROs. I was just looking into that because I got requested to be an IRO for an organization, and they're actually have actually just changed the rules on the 5%. They've thrown that out.
So so there's no number now.
There's not a threshold that I was able to see.
There's no threshold.
Right. So the error rate, when it was 5% or less, it would be just ignored. And so now if that rule is changed, I'm interested in reading that, but if that rule is changed, then the question then becomes, at what point is a statistical sample required or not required? I mean, I think if you have an error rate, of 20, 30, or 40%, you probably got a problem. But when you look, and I think with that one provider, that home health organization, they had, it was from 2014 to 2019. It was a 5-year period, and they only looked at 100 and something claims, like over a 5-year period. So you're basically it was an average of 20 or 25 claims a year for the 5 years. I mean, how do you even articulate that that's a good extrapolation?
Yeah, that's a great question. I'm actually looking for something. Robert Lyles just posted this, and he said, after seeing what happened in Texas, I'm very skeptical of state statisticians. And I'm trying to recall it. This was a case with HHS, and the individual, it was back in 2014. And basically what this individual did was they masked and they created this bogus methodology that they claimed to have used. And then the case went to a hearing and all of this stuff. The guy wound up losing his job over it because he took no responsibility, no accountability. He basically falsified the statistical analysis that was done. And if I can find it, I'll share it with you guys before the end of the show, because I had a copy of it, and I'll see if I can find it.
Hopefully you'll find it in the next minute and 15 seconds.
Is that all we have left?
Yeah, it is. It's crazy.
It's been a robust amount of time.
Wow, it's gone so fast.
Man.
It's okay. Almost sad.
Well, I will find a document and I will post the link to it so everybody can see it. So with the 55 seconds that we have left, I think we've covered a tremendous amount today. I hope some of it made sense. I think it did. I don't know. I'll tell you the one thing that's aggravating me in the last few seconds that we have together. So my wife convinced me to get a new phone. Okay. I've been a Samsung guy for 15 years. and I just got this new iPhone 13 Max Pro. I'm ready to throw this thing against the wall and just watch it break into 100 pieces. This thing, I'm telling you, I feel like a one-legged man in a butt-kicking contest with this thing. I really do.
I'm excited because now we can FaceTime all the time now.
I know. I can't wait to see your
That's
face on my
exciting.
phone, buddy.
That's exciting.
It is. All right. So here's the deal. In all sincerity, this brings us to the end of episode 15. This brings us to the final episode of 2021. I cannot tell you two how much I appreciate you, how much fun this has been, building our friendships, building our working relationships, and just coming together to bring not so sexy content to people in a lighthearted, easy to digest, and in an authoritative, factual way. I have had such a thrill hanging out with you guys doing these shows every week. I know we have some huge plans that are already on the way for 2022. We have a website that's going to be launching. Jordan's working on all kinds of funky stuff. We are committed to doing one show per week in 2022. We're going to pick a specific day, a specific time, and we are going to do our best to stick to that. But I do want to say on behalf of myself, thank you to each and every single one of you out there who tunes in, logs on, and just hangs out with us, whether you're doing it live, whether you're watching the recorded episode, or you're finding us on more than 80 podcast platforms. It means so much to us. In October, we were notified by Apple Podcasts that we were the fastest growing podcast in the business section. I told my wife we were number 210. She goes, of what, 211?
Like it.
So yeah, that's the kind of support I get right there. But my understanding was it was more than 2,000. So
Again, listen, you don't have to be the slowest. You just got to be faster than the slowest.
True.
that's very good.
Run
So-
from the bear.
From me to all of you out there, Merry Christmas, Happy belated Hanukkah, Feliz Navidad, Happy Kwanzaa. What's the other one that you guys said before?
Festivus.
Happy Festivus.
Festivus for the rest of us.
And may you all have a happy, healthy, and blessed new year. Eric, Jordan, I'll turn it over to you.
All I'll say is, for I didn't know what people were talking about until somebody was saying, I'm from the country here in Mississippi, and I couldn't figure out why the street sign was decorated and it said Leon, but it was for the first Noel. The guy was dyslexic. Anyway, that's all I got.
Thank God, Jordan. Thank God you at least have your looks to fall. Well, thank God you're a nice guy.
Yeah, that's it.
Well, I do
Eric,
appreciate
any parting words?
This was great. I mean, I think us coming together to decide to do this, it all started off with us just being guests on your Compliance Guy podcast. And we were fortunate enough to have people think that we were a dynamic trio. Yeah, look at that. And yeah,
Mug.
this was great. I'm looking forward to 2022, having
We're
a
gonna
regular day
have
where
a
we
lot
do
of
this.
topics. Yeah, 2022 is going to be busy. I mean,
And
it's
if
gonna be
you need me in a bigger picture, there you go. You could have me on your mouse pad, or if you just want me in general, here I am.
there you go. I think that also comes in a shower curtain, I heard. So that's cool.
A scrub brush.
That's great.
All right.
All right,
All right,
y'all.
guys.
Listen, on behalf of the Chuckleheads, on behalf of my family, their family, to all of you, may you all be blessed for this holiday season and have a wonderful, happy, and healthy new year. We'll see you the end of the first week of January, but until then, take care. Remember, be good to yourselves, but more importantly, be good to each other.